Uh, Good afternoon, all. I am presenting a study comparing immunoadsorption versus plasmapheresis as a pre-operative desensitization technique for ABOi-incompatible living-related liver transplantation, and it was a propensity score match analysis of 85 patients. As we all know, donor organ availability has been concerned for solid organ transplantation. ABO incompatible liver transplant strategy has come up as a promising option, and it can potentially eliminate the organ shortage. But we all know that AMR has been the main complication associated with the ABO incompatible liver transplant, which is associated with high incidence of vascular complications as well as biliary ductal complication, and which eventually leads to graft failure. Many studies have published that higher the baseline titer before the transplantation, poorer is the outcome. Effective desensitization before the transplantation has been the Achilles heel for ABO incompatible liver transplantation. Strategies for desensitization includes those which address the antibody production, which is rituximab, IVIG, and splenectomy, and those which address the existing antibodies, that is plasmapheresis, which is therapeutic plasma exchange, immunoadsorption, and cascade plasmapheresis. Our study was a single-center retrospective study which included two groups with 14 patients in each group. We compared clinical, demographic, intraoperative parameters, and short-term outcomes were compared. Rituximab was given to all the patients, single or multiple sessions of apheresis technique as needed for high titers. Our desired range was less than or equal to 1:16. And in our unit, we do not use preoperative splenectomy, local infusion therapy, or IVIG for desensitization. Our post-transplant immunosuppression includes standard three drugs regimen. We give low molecular weight heparin for the first 1 month to all the patients. ABO antibody titers are measured twice a day initially, followed by once a day, and then twice a week. Indication for plasmapheresis in post-transplant period is 2 log rise in titers or rise in titer to 1:64 or beyond. Acute rejection, when confirmed with the biopsy, we treat them with plasmapheresis, steroid pulse therapy, modulation of immunosuppression drugs, and IVIG as well. We cover up the patient with antibiotics, antifungal, and antiviral treatment. Color Doppler was done initially twice a day, and then after a week, once a day. TAC level was maintained between 10 to 12 nanogram for the initial first 2 to 3 weeks, and then it was maintained between 6 to 8. Initially, we had 118 patients to whom we gave rituximab. We excluded those patients from the propensity score matching since they were completely desensitized with rituximab alone. And then with the 85 patients, we ran the test of propensity score based on age, gender, BMI, etiology, and graft details. This is the flow chart of our department's protocol for ABO incompatible patients. 2 weeks prior to the transplantation, we give them rituximab, and we wait till the transplant day. We repeat the titer. If the titers are desired, then we go ahead with the transplant, and if it is more, then the patients will be considered for apheresis technique. Intraoperatively, we give methylprednisolone 10 mg per kg to all the patients during the anhepatic phase. In demography, there was no difference in the age and gender distribution, but we had a higher child score and MEL score in patients with adsorbent group. The grafts utilized were more commonly modified right lobe, followed by left lateral lobe, and then extended right lobe, which included the middle hepatic vein. In graft details, we included the type of the graft weight, GRWR, cold and warm ischemia time. There was no significant difference amongst them. This box plotting is suggesting comparable titer level of IgG and IgM in both the group of plasmapheresis versus immunoadsorption. After apheresis, both the tables show that there was a significant reduction to the desired level of IgG and IgM in both the groups. Overall complication, bile leak, and in-hospital mortality were comparable in both the groups. On day 7, we assess the allograft function based on the bilirubin, SGOT, and SGPT. There was no significant difference. So, to overcome the shortage of liver donors, ABOi incompatible liver transplant is being considered as an alternative strategy. We could desensitize nearly 1/3 of the patient successfully with rituximab alone. But if we see to the other set of patients, more than 2/3 were still had too high titers to be considered for the liver transplant. So to consider a liver transplant, they were considered for the apheresis first before the surgery. But the apheresis techniques have also got their own set of issues. Conventional plasmapheresis has a restriction to plasma volume that can be exchanged per session. And along with the removal of the pathogenic as well as along with the removal of the pathogenic titers, they remove non-pathogenic substances as well, like albumin, immunoglobulin, and coagulation proteins. Use of replacement fluids such as FFP, when they are used, they have also got their own set of complications, that is allergic reaction and transmission of infection. In our study, we had 3 patients who had minor allergic symptoms, which were managed conservatively, and they were continued with the plasmapheresis. Immunoadsorption cohort had significantly higher MELD and CTP score, but since they are more specific, single setting is needed to address the higher plasma volume to achieve the desired titer without any exchange of the fluid requirement. And adverse effect profile of immunoadsorption is relatively better than non-selective plasmapheresis. For occurrence of infection, the p-value was not significant. We had 6 patients with AMR, 3 in each group. 3 were managed conservatively, 3 could not make it. Vascular complication and other short-term outcomes and day 7 allograft functions were comparable, as we discussed. We could achieve a 100% desensitization rate in both the groups to desired level of titers before the transplant, with a median of 2 cycles of plasmapheresis per patient versus 1 cycle of immunoadsorption. Post-operative intervention was significantly high in plasmapheresis group. 2 patients underwent portal vein stenting, 2 patients had ERCP, and 1 was re-explored for bleeding. 1 patient in immunoadsorption group had renal replacement therapy. So to conclude, even after rituximab, a majority of the patients need apheresis. Both the techniques have equivalent efficacy as a desensitization procedure, and short-term outcomes were similar in both the group, except post-operative interventions, which were higher in plasmapheresis group. Immunoadsorption can be recommended for sicker patients as they had a higher MELD and child score. So those who are too frail to tolerate the fluid shifts, immunoadsorption can be offered. And a well-designed study can be structured to address the quagmire of desensitization in ABOi incompatible liver transplantation. Thank you.